So I would say that the standard approach for a patient with newly diagnosed large cell lymphoma, I would say that there isn't a single standard approach, that we really try to approach each individual patient, taking into account their distribution of disease, their burden of disease, and the goals of care for that individual patient. The first question that we would ask is, how confident are you with the diagnosis? And we know that second opinion pathology review is critically important, both in diffuse large B-cell lymphoma as well as across the spectrum of lymphomas. And making sure that the diagnosis has been confirmed by an expert hematopathologist is extremely valuable. Once you've confirmed a general diagnosis of diffuse large B-cell lymphoma, we then might want to look additionally at the individual biology of that patient's disease, because individual therapeutic approaches may differ based on cell of origin or other biological features. Here we would think about sort of a de novo diffuse large B-cell lymphoma versus a double hit or high-grade large cell lymphoma. Depending on the cell of origin, whether it's germinal center or non-germinal center, may influence certain decisions, such as whether or not to administer treatment to prevent recurrence in the central nervous system. That being said, the first question in terms of the overall therapeutic approach is, what stage is the patient? And we divide diffuse large B-cell lymphoma into sort of stage 1 or stage 2, or early stage large cell lymphoma, or advanced stage. Early stage is important because we know that some subset of patients who have early stage disease can be treated with less overall therapy. And here the decisions that we make in treatment of early stage large cell lymphoma is whether or not to give combined modality therapy, 3 cycles of anthracycline-based chemotherapy such as R-CHOP followed by radiation therapy to the involved field, or can you just give chemotherapy only approach? We have data using 4 cycles of R-CHOP chemotherapy with 2 additional doses of rituximab afterwards from the important FLIER trial, and this showed non-inferiority for 4 cycles of therapy as compared to 6, making this a very reasonable standard of care for appropriately selected early stage large cell lymphoma patients. For advanced stage disease, R-CHOP chemoimmunotherapy remains the standard of care, both in New York, America, and really worldwide. And there have been a number of attempts over the years to try to improve upon R-CHOP chemotherapy, either with substitution of agents or addition of other agents. None of these trials have ever borne fruit in terms of establishing a therapeutic approach that is superior to, meaning improved overall survival for the overall treated patient population when compared to R-CHOP alone. The recent Phoenix trial was a negative trial. This was a randomized trial of R-CHOP versus R-CHOP plus ibrutinib in non-germinal center patients. A subset analysis suggested that it's possible that in younger patients, maybe there could have been an overall survival benefit had it been restricted to such a subset of patients. But that was not how the study was conducted, and we in the field view this as a negative trial and do not routinely recommend R-CHOP plus ibrutinib even in younger patients with non-GCB large cell lymphoma. For patients who have high-grade lymphoma, many experts in the field continue to recommend a modified program known as rituximab and dose-adjusted EPOCH, or R-EPOCH. This admittedly remains an area of some controversy, and the data are not convincing. Nonetheless, many experts do recommend use of R-EPOCH for high-grade lymphomas, double-hit lymphomas. The decision is whether or not to administer prophylactic high-dose methotrexate continues to be an area of evolution. Historically, many experts recommended intrathecal methotrexate injections for patients who were felt to be at risk for CNS relapse. This is consistently and increasingly being understood as an ineffective approach. And for those patients who we believe do require CNS prophylaxis, usually we would recommend incorporation of high-dose methotrexate either during the course of chemotherapy or following achieving a complete remission with R-CHOP-based treatment. The majority of patients who are treated with rituximab and CHOP-based chemotherapy in the first line will be cured. The majority, but certainly not all patients. The likelihood of cure is influenced by disease biology, individual characteristics, crude prognostic systems such as the IPI or the revised IPI. And there certainly are a subset of patients with high-risk disease who face real risks of failing to achieve a complete response, or even if achieving a complete response, subsequently suffering relapse.